All right. Well, good evening, everyone. I just wanted to welcome everyone to Roswell Park's physician webinar. I am Rebecca Vogt. I am the media relations specialist for Roswell Park Comprehensive Cancer Center in Buffalo, New York. Now, we've been doing these for several weeks now. We do thank everyone for tuning in. We know that you guys, as both physicians and healthcare professionals, likely have a lot of questions surrounding the COVID-19 pandemic. Continue to have them, and they continue to come in. And we will be bringing you this free webinar series on Thursdays to cover a variety of topics and also feature a number of experts, all in the hopes of being a resource for you. Now, today, we are going to be looking at lung health and the cancer patient. I am joined by two wonderful physicians. We have Dr. Sai Yendamuri, who is the chair of the Department of Thoracic Surgery here at Roswell Park, as well as Dr. Nathaniel Ivanick, who is an interventional pulmonologist here with our thoracic team. Dr. Yendamuri and Ivanick, I guess first tell us a little bit about yourselves, and then we'll get into the meat and potatoes afterwards. So that being said, Dr. Yendamuri, if you don't mind starting off, share with the crowd just a little bit about yourself. Oh, you just got to unmute yourself.
Yes. My name is Sai Yendamuri. I serve as a professor and chair of thoracic surgery at the Roswell Park Comprehensive Cancer Center. I specialize in surgery for complex thoracic oncology conditions, including locally advanced lung and esophageal cancer, as well as mesothelioma.
Thank you for that, Dr. Yendamuri, and we'll switch it on over, pass the mic on over to Dr. Ivanick. Oh, you got to unmute too. Oh, there you go.
Hi, my name is Nate Ivanick. I'm an interventional pulmonologist. I joined the thoracic surgery team earlier last year in August, and have been thrilled to be made a part of the team, and have really enjoyed myself here in Buffalo at Roswell Park Comprehensive Cancer Center.
Thank you so much. Yeah, we are so happy to have you on board. Now, of course, as we all know, one of the most severe and critical side effects of the COVID-19 virus is respiratory distress. And tonight, Dr. Yendamuri and Ivanick are going to walk us through how we are tackling these risks and side effects of the virus for our patients whose lung health is already so compromised. That all being said, Dr. Ivanick, I know you have a presentation, and I think we will kick it all off with you.
Excellent. Well, thanks again very much for having me. And so I start very broad, and then I get into some specifics that I thought were quite interesting, and hopefully others will as well. So my talk is lung health and the cancer patient during the COVID-19 pandemic. Next slide, please. So I have no conflicts of interest to disclose. And just as a, next slide, a general outline for what I'll be covering, I'd like to touch on medical comorbidities related to cancer patients, as well as patients who may be infected with SARS-CoV-2 virus. I'll touch a little bit on tobacco smoke and its effects in the setting of the SARS-CoV virus. And then I'll touch more in depth on cancer, in particular lung cancer, in this setting of SARS-CoV-2, also known as COVID-19. And then a little bit about the paradigm that we currently find ourselves in that patients and individuals are getting nervous to seek care for really life-threatening conditions. And finally, I'll touch on some professional society guidelines, highlighting several that I think are really worthwhile for doctors and healthcare practitioners to check out. I want to also just emphasize that the information that I'm presenting is fluid. This is information, much of this has come from 2020, but this is our best understanding of the data to date. Obviously, we've seen a lot of challenges and changes come through with the COVID virus to date. And I would just add that that information may change. It may also be dictated in part by the local prevalence of the disease, such that decisions that we make may be reasonable with a certain level of prevalence of SARS-CoV-2. But if that prevalence were to change either up or downward, we would have to make decisions reflecting that. So I just want to emphasize the fluidity of what I'll be discussing. Next slide, please. So I believe everyone's aware of this, but just to start us out at a baseline. So SARS-CoV-2 is the cause of the COVID-19 virus. It's a novel beta coronavirus. We believe it originated in Wuhan, China, and has rapidly spread across the world to become a global pandemic. Up to 80% of the people who are affected by SARS-CoV-2, or infected, I should say, are asymptomatic and have a very mild disease. But that leaves a measurable number of individuals who have much more significant disease. And those are, of course, the ones that, that we are focusing on. About 15% of people with SARS-CoV-2 will become severely ill. And that is defined as requiring oxygen to supplement their oxygen saturations. And about 5% will become critically ill. And many of those will require intubation, mechanical ventilation, and support in an intensive care unit. Older age and comorbidities definitely have the lion's share of the individuals who end up requiring further support. And next slide, please. So this was a slide taken from one of the two most cited cancer papers that a lot of oncologists are referring to. This is Dr. Zhao et al. In Lancet. And basically, they perform a retrospective cohort study looking at patients from Wuhan, China, and identifying patients who are survivors and non-survivors, and trying to get a better sense for the medical comorbidities that may have increased their risk of having a bad outcome or having severe disease. In these instances, the ones that are highlighted, which we've all, I believe, heard on the news, would it be high blood pressure, diabetes, coronary artery disease, especially a lot of talk right now related to thromboses, chronic obstructive pulmonary disease. So all of these are found in greater prevalence in individuals who are non-survivors of COVID-19. Many cancer patients share these comorbidities as well. And so that's one reason that I think a lot of people need to focus on these things and work to identify kind of what the right approach to these patients is. If we could go to next slide, please. I wouldn't be a pulmonologist without discussing a little bit about tobacco smoke and its one more bad effect. And this is specifically related to COVID-19 and its binding. So I just want to state that obviously during times of high anxiety and times of stress and uncertainty in the world, people tend to fall back on emotional crutches, things that have kind of calmed them in the past, and tobacco smoke is one of those. And there are many chronic reasons why individuals should not smoke. And for a more up-to-date and in-the-moment reason, what we've identified is that tobacco smoke upregulates the ACE2 receptor, which is found on type 2 pneumocytes. Those are the pneumocytes that in our blood, in our lungs make surfactant, allowing our lungs to maintain adequate surface tension to kind of function at their optimal levels. And so tobacco smoke increases the amount of the ACE2 receptor that's present. SARS-CoV-2, actually, its spike protein, one of its proteins on the outside of its virus, actually binds to this receptor, and that facilitates entry into the cell. SARS-CoV-1 also did this, but SARS-CoV-2 actually has a higher affinity by 10 to 20 fold. And this has essentially led to the additional observation that if you compare smokers and non-smokers, smokers tend to have substantially worse symptoms. So their risk of severe symptoms is 1.5 times higher. The risk of ICU admission, mechanical ventilation, and death is actually 2.5 times higher. So pretty striking numbers when we consider a habit that's already not benign. Next slide, please. So what about cancer in the setting of COVID? So this is one of the other studies that I wanted to reference. This is a study, again, out of Wuhan, China. This is a retrospective study where they reviewed 2007 cases. They were able to identify cancer in only 18 of these cases. 5 of those individuals had lung cancer. And what they identified was individuals who have received some sort sort of anti-tumor therapy within the prior month tended to have a greater risk of adverse outcomes. So that might be chemotherapy, or it might be surgical therapy or radiation therapy. So again, a retrospective study, cause and effect is always more difficult to identify here, but I would add that the relative relation in a place of high prevalence of the SARS-CoV-2 virus indicated that there was certainly an increased risk of severe outcomes. This is actually my favorite cancer study, and I would encourage anyone with an interest to take a look at this. This is from Drs. Zhang et al. Out of the ESMO journal, and this is cancer and COVID-19. And I've actually adapted some of my some of this that had been a larger table. So, but I just wanted to point out a few things. So they looked at 3 hospitals in Wuhan, China. They identified 28 individuals with cancer. In these, lung cancer was about 25%, esophageal cancer another 4%, breast cancer 3%. I'm sorry, 10.7% for breast cancer, a total of 3 individuals. So my numbers here, you can see numbers and percentage. Had been diagnosed with cancer and were being actively treated in some way. So that might include surgery in 21, which is 75% of them, chemo or radiotherapy, targeted immune therapies, chemotherapy alone, radiotherapy alone, or immunotherapy. This was, they looked at these in both a univariate and multivariate analyses, and they identified that treatment of some sort within the prior 14 days increased the risk of severe outcomes. Next slide, please. So again, I want to emphasize these are fairly. Oh, and this is my sorry. This is my slide with the relative numbers of these. If we can, after just a moment, let's move on to the one slide forward, please. So I just want to emphasize this graph here. This was the probability of a severe event-free status correlated with the date of last therapy, meaning your chances of making it through without a severe event were substantially lower if you had received a therapy within the prior 14 days. The mortality rate in the cancer group was 28.6%, so quite high. And the hazard ratio for a severe event was greater than 4. So while the numbers overall for numbers of cancer patients are low, certainly this has made oncologists around the world sit up and take notice that their patients are the ones at high risk, and so something to pay attention to. Next slide, please. So I just want to jump to this. I received this in my email yesterday, and I thought it was pertinent and interesting. And I show this to make the point that I think both patients and providers are nervous, and they've taken the point that SARS-CoV-2 is a dangerous virus. And this is basically a bar graph. This was an online survey conducted with over 2,000 people, and they basically asked, how likely would you be to seek care from a physician if you felt it was necessary, but in the setting of COVID-19? And you can see across the board, including specialist doctors, less than half of people would feel comfortable doing this in the current setting of COVID-19. That obviously makes sense in the worries of the acute virus, but I would point out that in 2018, roughly 5,000 new cases of cancer were diagnosed per day. And as Dr. Johnson, our CEO, points out, cancer doesn't take a holiday. So these cases are there. They have not been diagnosed, though, and that may lead to the potential for worse outcomes if they're not identified in as timely a manner as possible so that treatment can be started. So now I want to touch base just a little bit on decisions in the setting of oncology patients and COVID. And if we could move to the next slide. So this was a really helpful article, and I would encourage everyone to take a look at this as well. This is basically regarding decisions regarding immediate cancer treatment in the setting of COVID-19. And the authors say that they recognize that not all cancers despite being diagnosed, need to be treated right away. But there are some cancers that, because of their speed of movement and because of their likelihood of reaching a stage where we would not be able to treat them adequately if they move too quickly, that those cancers should be prioritized with rapid treatment. They acknowledge that there are a few other things to consider, including the status of COVID in the community, and finally, the age and comorbidities of the patient. So they recommend stratifying individuals into low, medium, and high risk groups. And so I just want to point out a couple that that I think deserve special mention, and that is lung cancer. So individuals who have lung nodules or lung masses greater than 2 to 3 centimeters are in the high risk group, and those are individuals who should both receive treatment for their cancer as soon as possible, as well as and extrapolating that, also early diagnosis. So if you have a patient who had a 2 centimeter nodule who says, I'm just too scared to come into the hospital, I think that would be a patient where, after a shared discussion of this, that really bears a referral, because while the risk of COVID is there, and I don't think it's going away anytime soon, the risk of cancer might be there and growing. I think just a couple of others. This is not just limited to surgical approaches, but also radiation oncology and hematology oncology. But I would especially put in the plug for rapidly developing malignancies, that these should be considered despite our current pandemic. Next slide, please. These are a couple of decision models that I thought were really interesting and just recommendations for people to peruse at their leisure. There's one from Drs. Karafati and Patella out of the Journal of Thoracic Oncology. And here they talk about surgical management of non-small cell lung cancer, and just as pointers to assist with the decisions. There's another from Drs. Bana et al. From ESMO, and they review medical, surgical, and radiotherapies, and considerations for different stages of non-small cell and small cell lung cancer, and when is the right time for treatment, and maybe even, hey, this isn't our typical treatment, but what might I do here because of either patient concerns, prevalence of SARS-CoV-2 in the community, or other things, to arrive at the best possible treatment for their patients. And then near and dear to my heart are the recommendations from the American Association of Bronchology and Interventional Pulmonology, the AABIP, as well as from the American Association of Chest Physicians, or Academy of Chest Physicians, better known as CHEST, where they identify just a little bit about decisions regarding diagnosis of cancer and when it's appropriate to move forward with cancer diagnostics despite being in this this current pandemic. Next slide, please. And so I just wanted to point this out as our professional society guidelines. This is from the AABIP and CHEST, and these are indications that that need bronchoscopy. It doesn't matter if we're in the middle of the SARS-CoV-2 pandemic or otherwise. These are things that we need to act on. And those would include tracheal or bronchial stenosis that is severe and symptomatic, symptomatic central airway obstruction, including masses or tumor plugs, other things like that, massive hemoptysis. Obviously can't wait for COVID to die down, and stent migration if there was a stent that moved. So those would all be emergent indications that we would go to the bronchoscopy suite for. Urgent indications are the ones that we're most likely to find are pertinent to our patients on a day-to-day basis. If they have a lung mass, I think it's important to know that bronchoscopy is, or some method of diagnosis is indicated even in these current times, to ensure that we are treating patients adequately and getting them to the right settings appropriately. Mediastinal and hilar adenopathy that we're concerned may indicate cancer. If you have people with pulmonary alveolar proteinosis and are considering a whole lung lavage, if there was a foreign body aspiration, hemoptysis to a lesser degree, or symptomatic pulmonary infection in immunocompromised patients. I think the list is not meant to be exhausted. but is meant to indicate this is a good time to have a conversation with a specialist doctor to identify what should we do and what's the right time to do it. Next slide is my references, and thank you for your attention.
That was fantastic. Thank you so much. So thorough and well put. And you do, I know in the one slide, you do talk about best practices for individuals with procedures and whether to go to the hospital or not. And that kind of transitions us over to Dr. Yendamuri. I know he's going to touch a little bit upon that. Before I pass the mic, though, over to Dr. Yendamuri, I do want to mention one thing I forgot, and is that we are once he is completed, we are going to do a question and answer sessions. So if you have any burning questions that have happened right now during the presentation, and then also, when Dr. Yendamuri talks a little bit, you can always drop them down. We have a little chat bubble at the bottom. You can send it to all panelists. We're keeping an eye on them, and we will try to get to as many as possible when we get to question and answer. I've said my piece for that, so now I will pass that over to Dr. Yendamuri.
Hello, everyone. Good evening, and thanks for joining us. So as you can see, as Dr. Ivanick has pointed out, we are in a little bit of a tricky situation here. And this tricky situation is the result of three things. The first thing is that lung cancer doesn't stop. It's dangerous. It's the #1 cancer killer in the country today and among the most prominent of causes of death all over the world. So that's one situation. The second is that it looks like, for the time being, COVID is here to stay. It doesn't look like there was just going to be a surge and it goes away. It looks like it's going to be some sort of a continuous presence at different levels for several months to come. There may be a second surge coming in the fall. Hopefully it's not going to be severe, but this is not something that's going to go away in 2, 3, 4, or 5 weeks. The third thing is that we cannot, because it is here to stay, and because the patients who develop lung cancer are also the patients who can develop complications from COVID, we have to figure out a way to treat these patients safely. And we have spent a lot of time and effort at Roswell Park to develop strategies for treating these patients. And over the next few minutes, I'll point out some of those strategies that we have. And I think some of them have been borrowed from other practices, and some of them have been actually borrowed from a lot of primary care practices who have managed to do this reasonably well, and we've incorporated that into this. So at the outset, I would encourage patients to not make decisions of whether they should have a lung cancer taken out or not on their own, because they don't have all the information and expertise that they need to make that decision. So in order to facilitate shared decision-making, we encourage all new patients who need a consultation for lung cancer evaluation or surgery or chemotherapy to at least have a virtual consult with us. Now, what happens with the virtual consult is that the first thing is we sort of triage cases out. There are plenty of situations where the treatment for a potential malignancy or the diagnostic workup for a nodule is not urgent, and it is safe to wait a couple of months. For example, if you have a small lesion, less than a centimeter, that can potentially be watched. If you have typical carcinoid disease, that can certainly wait, and we can look for an opportune time to treat it. However, I think it's difficult for patients, short of having specific expertise, to make that decision. So I would encourage patients to make that decision in consultation with an expert. So one of the things we've rolled out extensively is the ability to deliver virtual consults. So that's step number one, right? Step number two is, let us say a patient does need to be evaluated and treated in a timely fashion, right? And has to be done now. We strive very hard to decrease the number of touches, which means typically a patient comes to us with a 2 centimeter mass. That patient may need a biopsy. That patient needs a PET scan, some lung function tests, then planning for surgery. So we'll need an anesthesia evaluation and so on and so forth. Once we've figured out that this is the most likely path on a virtual consult, what we tend to do is string all of these together on a single day. So very often we'll try our best for the patient to have a PET scan, a lung function test, an in-person meeting with the surgeon or the bronchoscopist, and a pre-op evaluation by anesthesia all in one day. So that the number of touches, the number of times that they have to come into any facility or step out of their house is minimized. Okay, so that's the second thing we've done. The third thing is that if any patient needs to have surgery, we advise that they should be self-quarantined for some time before they come into surgery. So from the time the decision is made to surgery, typically the surgical date is a couple of weeks away. We advise them and we teach them how to self-quarantine and self-isolate to decrease the risk of exposure before surgery. The fourth thing is every patient coming in for surgery has a COVID test the day before. This helps us in many ways. First, it decreases the risk of that patient being operated on if they have active COVID. Because unless it's an emergent procedure, if a patient has COVID, we can wait for 2 or 3 weeks and then deliver the therapy safely. So from that point of view, it helps us. It helps the patient decrease the risk of complications after surgery or any kind of treatment. The second thing it does is it decreases the risk for other patients in the hospital, right? So the chance of a COVID positive patient being in the hospital in this situation with a complication is decreased. And with that, that decreases the risk of other patients in the hospital contracting COVID. And third thing, and this is not to be taken lightly, it decreases the risk of COVID transmission to the staff. And thereby, when the staff has a decreased risk of developing COVID, they have a decreased risk of transmitting it to other people, right? So this particular testing policy has multiple effects in decreasing the risk of problems with COVID after surgery. The fourth thing that we've done is that visitation is limited. And that's important because we want to decrease the density of people in the hospital at any given point. So if anyone walks into Roswell today, I would say there are probably 1/4 of the number of people in the hospital than there were 2 months ago. It doesn't mean fewer patients are being treated. It's just that the number of patients who are not involved in patient care has decreased dramatically, and that is with intent. Because the greater the population density, the greater the chance of transmission. So it's a strategy to cut it down. Now, it's difficult for people to have surgery and recuperate from surgery and not have a chance to communicate with their family, right? Because that's tough. Surgery, recovery from surgery, requires emotional support. So to improve upon that, we give patients, every patient coming in who needs it, an iPad so that they can virtually communicate with their family and keep in touch. So while trying to optimize their outcomes from surgery, we are trying to emotionally support them as much as possible. Then the last thing, in a patient who's at particularly high risk for COVID and is a marginal candidate for surgery, we look for alternative treatment options. For example, in some cases, we might consider stereotactic body radiation therapy to treat these patients instead of surgery. And these are, these decisions are made based on, a risk stratification of the disease, risk stratification of the patient, and after a thorough discussion with the patient, and after a thorough discussion of the case and tumor board. Our tumor boards are still very active. We conduct them virtually. I would say in some ways it's even gotten more efficient because I don't have to walk from my office to the tumor board. There's no 5-minute delays. Everyone's on at the same time. It actually works quite well. So in this way, we have fortunately been able to treat lung cancer patients surgically without a problem. Over the last 4 weeks, we have probably done about 35 to 40 surgeries on patients with lung cancer, and touch wood, we haven't had any COVID-related complications or even a COVID positivity in any of these patients. But this takes a lot of diligence from the point of view of screening, from patients willing to self-quarantine. We can teach them how to self-quarantine before the surgery, but they have to do it. And our patients have been superb at following those instructions and protecting themselves and others in the process. And the hospital administration has done a wonderful job in getting these protocols together and in making sure they're followed to the T. It takes all that extra work and discipline, both in terms of patients as well as physicians, to get these results that we are seeing right now. With that, I'm happy to take any questions that anybody has.
Fantastic. Thank you so much for kind of bringing that in that four-pronged approach, Dr. Yendamuri. Just a couple of things to kind of throw out there. First, I don't know who wants to tackle it. And you guys both really did touch upon it, but I mean, really, like, is it safe to refer my patient to Roswell Park right now? Like, what else can we really drive home here? And I know, Dr. Ivanick, you kind of summed up really well with what Dr. Johnson had been saying, but either of you, really, what else can we share to really encourage the healthcare community and our referring physicians to know that, like, we are good. Patients can come here.
Yeah. Dr. Ivanick, do you want to go first?
Sure. Thank you. Well, so I think a number of things. So yes, I do think it's safe. I think as we look through, every staff member entering the hospital every single day is asked screening questions. Temperature is taken. They're given masks if they're in a clinical setting that day. And I think there's been a really strong encouragement. If you're not feeling well, don't come in that day. Like I think all of us are emphasizing both patient safety as well as staff safety. And so I think that we are far enough into this pandemic that we do have information on how COVID is transmitted and risk factors and things that we can do to mitigate that risk. And so I think going to Roswell Park is much safer than going to the grocery store, for instance. I think our relative risk is substantially lower. There are some things that people have to do. You have to go and buy groceries, and if you've got cancer or you may have cancer, you have to get it diagnosed.
I think I agree with Dr. Ivanick. It's quite safe to come. The important thing also, I think, the important point I would like to make is that we risk stratify patients on the initial virtual consult to make sure that patients who don't need to be here don't get here, right? Everyone with a lung nodule doesn't have to be evaluated, but we take that into consideration. And we will take a look on the initial virtual consult if that is something that can just be followed with a CT scan, say in 3 months or 6 months, and then evaluate at that point versus needing further investigation today. We take great pains in making that triaging system work because anyone who doesn't need to be here shouldn't be here. At the same time, anyone who needs treatment gets it safely.
One question we have coming in, is there any research being done on the long-lasting effects of COVID-19 and the lungs?
So I'm sure that we will see multiple research, both from a clinical and translational perspective in these terms. It just hasn't existed long enough for that question to be answered. But all of these patients are going to be followed very, very, very carefully. You know, so having said that, if looking at the trend of other viral infections, very few of them have long-term effects. Um, but you know, it's that the verdict is, you know, the jury is still out on that issue with respect to this. Dr. Ivanick?
Yeah, I would absolutely agree. I think, you know, many people suffer from influenza pneumonias on a yearly basis and other diseases. And while there may be small elements of scarring that are present in some, oftentimes the lung has so much redundancy that that long-lasting effects are not really a feature of many viral pneumonias.
We talk about research. Do you want to also make that shift over to trials, clinical trials? I mean, is the pandemic affecting clinical trial enrollment? What can be said about that?
Absolutely. At this point, the pandemic is affecting clinical trial enrollment because we have sort of put clinical trials on a hold. Having said that, as we are realizing the pandemic or the coronavirus is here to stay, we are slowly opening up clinical trials. But a lot of thought is going into which trials are going to be opened. So only high priority clinical trials are going to be open, and we are going to open that starting sometime this month. But again, a lot of thought has gone into and is going into which trials open up.
Thank you for that. Earlier, Dr. Yendamuri, you did mention actually something about the tumor boards going on, how you could just kind of tune in and how it's been easier for you. That does kind of lead it to sort of like precision medicine and such. And we have a comment coming in just about, do patients on targeted oral chemo fall outside of any sort of these extra safety guidelines?
So, you know, I don't prescribe oral, you know, targeted agents, but I don't think so, because targeted agents actually are not as immunosuppressive as regular chemotherapy. That is their big advantage. And the problem with regular immunotherapy, and why we have to be especially careful in patients having, you know, chemotherapy, is that it depresses the immune system. Targeted agents typically don't do that. So I would say that it's pretty safe to give targeted agents in this time. Dr. Ivanick, I don't know if you have any further input on this.
Nothing specific, Dr. Yendamuri, other than that I would add that the BANA article that I referenced in my decision models goes into both immunotherapy as well as some on targeted therapy. And since the relative chances that an individual might be on targeted therapy, I think would, you know, those individuals make up a small subset of those populations. I think everything has to be taken with a grain of salt, in that how many numbers do we truly have in each group? But the BANA article that I think that's the best that I came across referencing that.
Fantastic, thank you for that. Well, our time does continue to fly by, as it does every week. I feel like we've kind of, there were a lot of questions that, like, you know, were kind of asked ahead of time that you did really touch upon, so no need to really rehash a whole lot of that. Kind of with the time we have left, I want to open it up just to closing thoughts from both of you. Whoever wants to go first.
Dr. Ivanick.
Thank you. I would say, you know, I appreciate being allowed to share some thoughts related to this. I think that what I attempt to do as part of the Department of Thoracic Surgery and as an interventional pulmonologist, when I'm seeing patients, is really think, what are we going to, if I make a diagnosis of cancer in this individual, how are we going to move forward with therapy, and are we going to move forward with therapy? And I think that in my 6 months here, I've seen a very thoughtful approach from all of my colleagues, both within thoracic surgery and outside of it, in that we really attempt to involve the patient in decisions, the referring provider, and I think we continue to do that now. And I would just say that that discussion can be had in a virtual visit. It can be had in person, but all of these are important things to consider.
So, you know, my thoughts are, we're all worried about coronavirus, and justifiably so. Thousands of lives have been lost, and we are going to see that a few more thousand will likely be lost. But I'm also worried that in the anxiety around the coronavirus, if people don't seek the care that they ought to seek, then even more lives may be lost that are not COVID related, that can be saved. And I would caution everyone that to let that not be an unintended consequence of the COVID epidemic. Of course, preventing that requires thoughtful considerations and planned action, but I think we really have to keep that in mind as well.
Thank you for that. Thank you, both of you, for taking time this evening. I think one thing that has resonated from both of your closing statements really does hone in on our comprehensive approach. You talk about, having a care team that is there to answer any questions that a patient may have, whether it's through virtual visits or, what have you. It's everyone's all in it together as a team. And that's the approach that should be continued taken as we all kind of navigate these waters together. A good point made earlier is that, especially with the question about research being done in the long term, because we kind of do go day by day, and that what's being done now is going to basically be written in the medical textbooks of the future. So it is truly history in the making with everything, and we will stay tuned to see kind of what's next. So again, Dr. Yendamuri and Dr. Ivanick, we want to thank you both for taking time out of your busy schedules this Thursday evening to join us, and then also to all of our attendees as well. We really appreciate the time that you take out to tune into these chats for us. Now, if any of your burning questions weren't answered, if you were a little too shy and didn't put one in the chat, or we end this chat and then all of a sudden you say, oh darn, I was going to ask that, but I forgot, we do encourage you to tune into any future webinars that will address even more topics and questions. We do also consistently update our COVID-19 page on our website. It has additional FAQs and more. You can always check that out at roswellpark.org/coronavirus. The video from today, luckily, will be available to view on demand, and also a link will be sent to your email. And we do encourage you to stay tuned to our landing page for all of these chats. It's roswellpark.org/chats, and also your email to register for any upcoming webinars. We'll keep you posted on when those are happening. Have a wonderful Thursday evening, and thanks again for tuning in, everyone. Bye.